So intended parents are really treated just like the rest of our clients that come in for reproduction assistance. We're always checking to make sure that the sperm is okay. So one of the first things we do is a semen analysis. The second thing is for the female, we're looking at how many eggs they might be able to make in a month. That's very important. That's called ovarian reserve. So for ovarian reserve, we do some blood testing. We do what's called anti-Mullerian hormone, which will check to see again what's the potential for this ovary in making eggs. Is this ovary going to be making one egg when we give her the medications, or are they going to be making 10 eggs or 12 eggs or even 20 eggs? The other things that we look at will be the thyroid tests, and then we look at something called prolactin, which is a hormone of breast milk. That's in general what we do. So again, for the male, we're looking at sperm. For the female, we're looking at ovary and how many eggs we're going to have. One of the great things that came out of COVID is our capacity to be able to do telehealth. So the good news is at the beginning, we spent a lot of time through a telehealth opportunity to be able to discuss with our international clients their concerns and exactly how the process goes, because that's the most important thing is, how is this going to go, and have them have confidence in us to be able to proceed, because this is really difficult. So the most important thing is that they have to show up here, at least the male, at least once, because again, we need his sperm. So we can go ahead and freeze the sperm when the intended father comes. For the female side of it, we will need to have them here at least 2 to 3 weeks, unless they have a clinic in their international home country that they can use for being able to be what's called monitored. Okay? So there's about a 2-week period of time where they need to be monitored to be able to see how their eggs are going. So in general, the male, only one visit. The female would be at least 2 weeks would be the best. So fertilization essentially means egg and sperm together. So in vitro fertilization means outside the body. So we obtain the sperm from the man by collecting it in a cup. And then the females, after undergoing a 2-week process of getting medications to make eggs, we get the eggs out, going through a process that's called retrieval. When we get the eggs out, we give that to the embryology team. The embryology team then looks at the eggs. They do what's called stripping the eggs. An egg has cells that surround it that keep it alive when it's inside our body and as it transports itself through the fallopian tube. So it strips the outside of the egg. Near the zona pellucida, there's cells called granulosa cells. After they do that, then they pick the sperm and they put it inside. And then the next day, we look to see if there's fertilization. Here at Pacific In Vitro, we offer the standard genetic testing that most people would be offering. So we do tests for the male and the female before we create embryos to see if they have any genetic issues with respect to, for example, sickle cell anemia, for example, cystic fibrosis, Tay-Sachs. There's a whole list of almost 300 to 400 things that we can test for before we do the in vitro. That is important because if there is a genetic carrier to one of the patients, we can actually look then at the embryo and figure out if it's affected or not. So we can look at it, for example, to say, hey, does this embryo have sickle cell? And we can actually look at it and then pick an embryo that doesn't have sickle cell. So that's called disease, looking for a disease, pre-implantation genetic evaluation for diseases. There's also something called testing, where we're testing the embryo for what's called the 46 chromosomes. In those 46 chromosomes, if, for example, a person has an extra chromosome like 47, we can test for any of those abnormalities, or if they have 46 chromosomes. The common ones would be like 47 plus the 21, that would be called Down syndrome. So we can look at the full genetic chromosome makeup. There's 2 chromosomes that make the sex chromosomes. That's an XX and an XY. And then there's the other 22, which are called autosomals. So we can look for both disease and we can look for pre-implantation testing for the chromosomes. So the numbers of embryos being transferred are determined mainly by guidelines that we use from the American Society of Reproductive Medicine. So they have guidelines that look at the female age, they look at how many times they have had success or failure previously, and we look at how the embryos look like and what stage they're at. Embryos, we usually can transfer them either on a day 3, those are usually 8-cell embryos, or on a day 5, which is called a blastocyst. So embryos that look fantastic and the female age is extremely young, we would be usually recommending only one. If the female is older and has got embryos that do not look fantastic and they're, for example, on a day 3 embryos, maybe we would recommend 2. So again, we go with what's called the American Society of Reproductive Medicine. Those are our standards, and I don't want to say national standards because obviously American means United States, but they pretty much fall in line with international standards. One of the most important things in having success is obviously trying to pick the best embryo. And we have an amazing embryology team that's always looking at these embryos. And even if we don't do the implantation genetic testing to know that an embryo has been tested to see what its genes are, we do a lot of other non-invasive testing, whereby our embryologist, which is really world famous, he's one of 2 that first started this whole thing called non-invasive testing of the embryos. And he can compare the embryos without even touching the embryos, without sending any cells to be looked at for genetics, with other embryos that have been tested before, and be able to tell us which is the best embryos to put in or embryo to put in. So part of success is being able to have a great embryology team that can choose or tell you either tested or untested embryos which might be the best to put in. So that's really extremely important. The other thing is we have very good success rates. Much of it depends on the physician and how it is that we do the transfer, how well we prepare the uterus lining for the surrogate that's going to be carrying the pregnancy. So those are the most important things that we make sure, again, that the embryo is the best that we're putting in, have a great embryo team, and that the uterus is prepared the best it can be for placing the embryo back in. So for a gestational carrier, the most important thing is to get her history. How was her history of prior pregnancies? How were the deliveries? Were there any complications through the deliveries? Was there high blood pressure? Was there diabetes? And really, history is one of the most important things that we can get. The physical examination is actually fairly simple. The physical examination has to do with doing a transvaginal ultrasound. And we look at the uterus and we see, how does the uterus look? How is it tilted? The uterus can be forward, can be backwards, tilted. And this is important for when we get to the transfer point, to be able to figure out how to do the transfer simply and easily. Then we look at the structure of the uterus itself. So we're looking at, are there fibroids present? Do we think that there's a polyp present? And if so, we do something called a sonohistogram. And that's when we put fluid inside the lining of the uterus, and it helps us be able to figure out whether there's any other procedures that need to be done. For example, if there's a large polyp, the polyp would need to be removed. Those are the most important things that we do with respect to the history and physical. With respect to the laboratories, we'll go ahead and we'll evaluate, for example, any concerns we might have. For example, the female comes in and she's on thyroid medication. We'll go ahead and check, how's her thyroid? Is her thyroid under control? Is she on high blood pressure medication? We'll do, again, blood pressures and vital signs to make sure that the blood pressure is good. We can check other hormones that just look at the balance of the hormones, for example, prolactin, which is the hormone of breast milk. And then there's ones that we have to do standardly. We have to meet criteria with the Food and Drug Administration and with the Centers of Disease Control with respect to third-party reproduction. And these are blood tests that are timed for at the point that we need to make sure that, again, the surrogate is protected from any infectious diseases, okay, that the embryo might have versus what the surrogate might have. So this is really, really important. These are all time sensitive. We look at things like hepatitis B, hepatitis C. We look at things like syphilis. We look at things like gonorrhea. We look at HIV, to give some examples. So the most important thing for the surrogate is for her own system, her own ovaries, to actually be shut down. That word is called suppression. Okay? And that's really important because usually we make 1 egg a month and we actually have to suppress the whole system from making any eggs. So when we do the suppression, most of the time we'll give birth control pill first. And then a few weeks into the birth control pill, we give something called Lupron. Lupron is a medication that is an injection medication which goes to the brain and turns off the brain's capacity to send signals to the ovary to make one egg. So when we use the Lupron, it quiets the ovaries and the message from the brain to the ovary. Actually, if we give Lupron for a very long time, we're turning off all the hormones. After we turn off the hormones, we then have to bring back hormones to help the uterus to be able to be ready for that embryo. The first part that's given is something called estrogen. Estrogen can be given in several different forms. It can be given orally, it can be given by patch form, or it can be given by injection form. That usually occurs over approximately a 2-week period of time. After those 2 weeks of being on the estrogen, we make sure that the uterus looks like it's ready, that it's prepared for an embryo. That's done with an ultrasound. So we do the ultrasound to make sure that it's ready for that embryo to go in. At the point that we think that the uterus lining has got the architecture and the size required to be able to have the best chance of implantation, we then add something called progesterone. Progesterone can also be given either in injection form, in oral form, or in vaginal suppository form. In the United States, we yet don't have the subcutaneous forms of giving progesterone, but we're hoping that we're going to have that in the very soon future. So again, most of them is injection, it's an injection in oil, oral, or vaginal for progesterone. We give that for the amount of days that the embryo is developed for. For example, if we're having a day 5 embryo, we'll give the progesterone for a total of 5 days, meaning that the embryo will be put in on the 6th day. If the embryo is a day 3 embryo, that progesterone will be given for 3 full days, and the embryo would be put on the 4th day. At that point, the surrogate has to continue the progesterone and the estrogen until we know there's a pregnancy. At the point we know there's a pregnancy, the progesterone is actually continued. Why? Because progesterone is important for keeping the uterus really quiet and not from contracting. It keeps the uterus lining in balance and again, very, very stable for the implantation of the embryo. So the first part of medications are birth control pills. Those can go anywhere between 2 weeks and 6 weeks, depending on when the best time for the transfer is. Part of this depends on if it's going to be what's called a fresh transfer, where you're going to have also the intended parents cycling at the same time. So we have to wait for their embryo preparation. So if a intended parent is getting their embryos fresh, meaning they're not being frozen, they're going fresh, then we have to synchronize the intended parent with the surrogate. In general, though, it's about 2 to 3 weeks of birth control pills overlapped with what's called the Lupron, which turns off the hormones from the brain to the ovary, for another approximately week to 2 weeks. Then there will be the estrogen for about 2 weeks, and the estrogen and the progesterone for about 1 week. So the full process of the medications will go from about 5 weeks to about 7 weeks. So the first half of this whole cycle organization is a birth control pill. The birth control pill, because it can be given anywhere between 2 weeks and 4 weeks, the reality is during that time, the surrogate almost doesn't have to be here at all. I mean, all we really need is when the surrogate is ready to undergo what we call starting the Lupron, the hormone that turns off the brain to the ovary interaction, which the brain tells the ovary to make one egg. At that point, the surrogate will bleed when we stop the birth control pills. So the moment we stop the birth control pills, the surrogate will bleed. At that point, we want to see the surrogate once to what's called to do the baseline. The baseline makes sure that the ovaries of the surrogate has no eggs being developed, so that we're starting at what we call a baseline with no hormones on board, so that we can give back the hormones. So that's one visit there during the cycle. After the baseline visit, a few days later, you're going to start the estrogen. The estrogen is given for about 2 weeks before we start the progesterone. During those 2-week period of time, usually you come in 3 times for blood tests, and during one of those visits or 2 of the visits, you'll have an ultrasound to make sure that the lining is doing good. So again, the estrogen helps build the lining for the embryo to be able to be implanted. Once we reach the perfect lining depth, how thick the lining should be, and the architecture of the lining for the embryo to do the best, that's when we start progesterone. At the point we start progesterone, we then just see you for the embryo transfer, which will be somewhere between 4 to 6 days after taking the progesterone. So in total, the baseline, at least 2 or 3 visits during giving the estrogen, during that 2 weeks of estrogen. And then the next time we see you is at the time of the transfer of the embryos. It's fairly actually short. Considering the process is somewhat complex for our laboratory, to make embryos, and it's kind of complex for the intended parent to be able to do the stimulation and to have the eggs, and then for us to put the egg and the sperm together, the day of the transfer is actually fairly easy. You come in and make sure everything is on time with respect to the embryo development. You get placed in a room that's a special room that has stirrups on it, and we do an ultrasound guided procedure. We put the speculum in the vagina, and we take this tiny little catheter and we place it through the cervix into the uterus. The catheters are very, very small. They're smaller than what would be an insemination catheter. And then the embryo is placed in when the embryologist brings it in. The whole process, in all honesty, usually is less than 2 minutes. To imagine such a complex process prior to the transfer, the day of the transfer is actually a fairly easy day. And if bearing any complications or any problems in putting in a catheter into the cervix, into the uterus, it's usually less than 2 minutes. Usually it's not painful at all. Obviously, having a speculum in the vagina isn't the most comfortable thing, but usually because most surrogates have had pregnancies before, their cervix is already kind of soft. It's very easy to get these catheters in. And because the catheter is only in there for a few seconds, literally, pain is very low. Well, if the transfer fails, it can fail because of the embryo. It can fail because of the embryo quality. It might have nothing to do with the surrogate. So one of the first things we look at as physicians is we look at how was the embryo quality of the embryo that was placed inside. So many times there's no other procedure that's done. The only other possible procedures that sometimes get done have to do with, again, looking at that uterus, making sure that there's no polyps in it, or making sure that there's nothing in the uterus proper whereby an embryo would find the uterus inhospitable. In general, not much is done. Usually an ultrasound just to make sure that the uterus at baseline looks good and is thin and there's nothing in there to interfere. We also look at how the transfer went. If we had difficulty with the transfer, for example, because it was difficult for us to get the embryos in, sometimes the cervix might be opened up a little bit. That's called dilation. We can do that in the clinic with very minimal discomfort. So sometimes we also might do some blood tests, for example, if we're really worried. Again, if it's a surrogate that's got thyroid problems and we aren't sure whether the thyroid may be playing some role or if the thyroid is not within balance where it should be, we might do some blood tests. But in general, again, many times this falls back on the embryo and the embryo quality and not the surrogate or the surrogate's uterus. So the risk of an embryo transfer cycle is actually minimal. The most concerning risk would be whether there would be an infection that would be caused by going through the vagina into the cervix. We do not clean the cervix with antiseptic, for example. If you're doing, like, for example, a large surgery, you'd be getting something like betadine to be able to make the area as most antiseptic as possible. In this scenario, we cannot do that because it actually kills the embryos. So we can at most wash the vagina, the vaginal area, with fluid that's similar to the fluid that the embryo is carried in. That is why we make sure that no one has any infections prior to us putting the embryo in. For example, if you actually have gonorrhea or you actually have chlamydia, we can actually track the infection from the vagina into the uterus. I've never seen that before, luckily. We take precautions prior to putting in the embryos by testing everyone to make sure they have none of these diseases. We also will give women antibiotics. We give antibiotics prior to the transfer. Many people don't understand why we give antibiotics. One of the reasons we give antibiotics is because it is an unsterile procedure. Infection would be the number one possible risk that, again, me doing this for 35 years has really not seen any significant infections. Discomfort is unlikely. It really is not a painful procedure, especially with surrogates that have had babies vaginally. Their cervixes, again, are soft and kind of very, very easy to get into. The other one is if one has more than one embryo placed. Let's say that two embryos are put inside of the female and there ends up being the possibility of having twins. It can be a little bit riskier for the surrogate. If there's any problems with one of those embryos, if there's bleeding during the early pregnancy. So again, some of them has to do with putting in even potentially more than two, which is a very, very, very rare. There's also the rare circumstance that can occur whereby one embryo is put in and the embryo can split. When it's put in, it can actually become a natural twin because natural twins can occur. And obviously, the more embryos that are placed, which is why we don't do that, the riskier that is for the pregnancy itself and for the delivery itself or for early delivery. Well, medications are given. So anytime a medication is given that a person's not used to, there can be an allergic reaction to a component of the medications. These medicines, many of them are injection forms. So at the place where one is injecting, one can have inflammation or what's called erythema, kind of a reddening of the area. With respect to the progesterone, that's the hormone that's given at the second half of the cycle. That is an oil. And when we put those in the gluteus, which is in the butt, those intramuscular shots can be very uncomfortable. And they can also start forming kind of little welts in the buttocks area. That's probably one of the largest complaints we have. I don't know if I want to call it a complications, but I do want to call it a discomfort. It can become a complication if a person is allergic to what the progesterone is carried in. It's carried in an oil type of molecules. So one can be allergic to different oils that the progesterone is in. And that can be actually something that can be very bothersome. We tell the girls to massage out the area where the progesterone is placed. We tell them to use some warm pads. Obviously, at any point, if things with respect to the injection isn't going well, we can switch up to different forms of giving the progesterone. They can be given orally if need be. The oral progesterones, when they go through the liver, can have a little bit of a effect for desire for sleep. Progesterone is a sleep hormone. It's a hibernating hormone, so it can make you a little bit tired, but that's normal of that progesterone. It's normal of early pregnancy also. If we use patches, for example, with the estrogen part of the cycle to make the lining look good, there's people that are allergic to the estrogen patch, to the adhesive. If so, again, we can just switch out to an oral pill or to an injection form. There's also injections of estrogen that can be given, again, in oil. If a lot of estrogen is given, for example, and let's say the person is a smoker, we would hope not so, because that's one of the things that we certainly don't encourage for the surrogates to do. Um, Estrogen is a hormone that can cause blood clots. So it would not be out of reason. I've never seen it in a surrogate. Our surrogates aren't smokers. The estrogen levels are kept in safe areas, in a safe number. But again, if the estrogen gets very, very high, there could be the possibility of increasing a risk of a blood clot. But again, this is very, very rare. And I've been lucky enough not to see this. So usually the first pregnancy tests are taken somewhere between 11 and 13 days after the transfer. It depends if it's a day 3 transfer of an embryo or a day 5. So the more developed the embryo is, for example, day 5 is considered a blastocyst. A day 3 usually is considered an 8 cell. With respect to the day 5 blastocyst, we would be doing that pregnancy test somewhere between day 11 and day 12. So at that point, we get a number. We then repeat that test 2 days later to make sure that that number is going up or, unfortunately, if it's going down, because miscarriages can occur. Even miscarriages can occur if an embryo has been testing and it's an absolutely normal embryo of normal genetics per the tests that were done, since no test is 100%. At that point, we then will do another blood test on what's called day 25 after transfer. So there's certain days that we do the blood test to make sure that the pregnancy is going well. So blood tests can actually be done in any laboratory. It doesn't have to be done in our laboratory to be able to establish those numbers. We would want them to be done at the same laboratory because different laboratories have different references. And we need to see that there's about a doubling of the number between the first number we do and the second number we do. We usually tell people that they're pregnant after the second number that we do, just to confirm that the numbers are doubling and they're going up.